And we're delighted to have you here. So I'm going to turn it over to you now.
Thank you so much, Pamina.
I didn't even claim you.
And Pamina was my advisor, my doctoral advisor 7 years ago. So I am part of the family here. It's great to be back at UCLA. I love coming back. And I am, like Pamina said, I'm faculty in infectious disease medicine and epi and at UCT. And today I'm really going to talk about something new, I think, and something I'm very passionate about in my work as an American academic that lives in South Africa is really about prioritizing global health equity. I'm going to give an example of my research around PrEP and pregnancy, but first I'm really going to start with focusing on equity. So for those of you who know a positionality statement, I encourage you all to think about your position of power and privilege in the work that we do. In a global health setting, I have a lot of power and privilege. I'm graduated from UCLA. I'm white. I'm born in the US. I'm cisgender, educated women, and I live in South Africa with my family. I really acknowledge the systems and structures that have put me in this place. And I'm really committed to improving my understanding and practice around decolonizing public health research, guided by both feminist and decolonizing perspectives. So this is the outline of my presentation. So first, we're going to focus on reimagining global health. What's the problem in global health? I got to meet some colleagues from CDC China here today. So I think you'll empathize with me, and I'm sure a lot of you have worked outside of the country before. So we recognize there is a problem. And we're going to really talk about how to reimagine it, global health. I'll give an example of the UCLA and South Africa experience and talk about my ongoing research and collaboration, improving prevention of HIV and STIs in pregnancy, and then steps that we're taking to address global health inequity in our work, and followed by a discussion. So I hope to go pretty quickly so we can have a discussion at the end. But if you have questions, it's very informal, so please raise your hand. I'm happy to take questions as we go. This cartoon on the right here is from Madupai, and it talks about the power of privilege, which is the elephant in the room today. And around the elephant, there is racism, patriarchy, capitalism, coloniality, white supremacy, and lack of DEI that we're recognizing as we start this talk. So can you imagine this? 2 MPH students come from the University of Cape Town in South Africa. They land at UCLA for a 2-week visit. They visit campus, talk to some professors, visit some local organizations, read some reports. They write up a report about how to fix gun violence in schools. They publish their paper in the American Journal of Public Health. Can you imagine that? Hard to imagine, right? So now we're going to talk about reimagining global health. It's failing on equity. We're inherently failing on equity. The key reason is that we're steeped in this field of inequitable research practices and public health programming. We hold the power in the global north, and we're privileged. To bring equity, what I'm going to focus on here is really moving away from saviorism, that we're coming there to save people or save them from their own problems, to allyship, to working together. There's many obstacles to shifting power, but it's possible. No change can happen without our own demand in the global north. So why and how is it inequitable? This is a great paper. I'll give you all my references at the end, from Madupai as well in the Lancet. And what they talk about is global health is a discipline that holds within itself a deep contradiction. It was birthed in supremacy, but its mission is to reduce or eliminate inequities globally. So first, talk about where are the organizations that work in global health. This is a map from Global Health 50/50, and you can see that half of the organizations are in Europe, over a third are in North America, and only 7% are in Africa. Who are the leaders? Out of 20 global leaders, 14 are male, 17 are from high-income countries, and only 3 are from low and middle-income countries. The patterns of privilege prevail. Where does the money go? So despite our effort to give funding directly to LMICs, most of the funding, even in Fogarty, from the NIH, the Wellcome Trust, USAID, and Bill and Melinda Gates, About 70 to 80% goes to the global north. Who is publishing? So primarily, publications go to us in the global north. So stuck in the middle, a systematic review is a really interesting paper to read, is that your LMIC partners are generally in middle authors. In this study at UCSF, up in the north, only 16% of UCSF affiliated articles had a LMIC researcher as a first author. These are global health papers. 19% had a second author, only 14% had a last author. If anyone wants to do a systematic review on UCLA, I bet you would find the same thing. This is a paper from colleagues here at UCLA. Yan Wang is a colleague of mine, and she shared this with me actually, and said really published the difference between North and South publications versus South-South. So what people in LMICs want, they want to collaborate with people in their own communities and really have more of a South-South collaboration. In South Africa, we're really pushing for more South Africa-Indian collaborations, for example. However, if you see the pattern over time, they reviewed over 4,500 papers and less than a quarter involved a Southern institution. 77% were North-South collaborations. Most were single PI, mostly American or European, intervention studies, and South-South collaborations are increasing, but very slowly over time. Who is editing? So here are these papers really talk about non-white scientists appear very infrequently, and the challenging of the old boys club in academia. In this, specifically in this editorial here, you can see that of the 27 health journals, 303 editors, fewer than half were female, 68% were based in high-income countries, 34% in Europe and North America, and only 27% were women as editors-in-chief, and 73%, three-quarters, were in high-income countries. Conferences. If you've been to a conference lately, you know there's huge inequity in getting visas. So this is a picture from the AIDS 2022 conference where they were talking about HIV in Africa, and no one could attend. So it was an empty stage. And even the CDC Africa chief had difficulties getting into Germany. So it continues to be a problem of even getting to conferences outside of Africa, for example. So again, back to this cartoon, the global health and development, the global health, how we like it, is we talk about charity and philanthropy, that we're going to give back to those people in the South. We give aid, donations, development assistance. We want to be there for them to be dependent on us, and we're going to be there to save them. The global South, and this is research that has shown how they want collaborations to be really based around human rights, equity and social justice, reparations, autonomy, respect, self-determination, and self-sustenance, and not just delivering aid. So what's the problem? If the privileged, we dominate global health. We lack the lived experience. Our privilege, as I presented before, prevents us from seeing things clearly. We're away from the real problems and the real solutions. No matter how good we think our hypotheses are, they still come from our side. We make mistakes even though our intentions are good. We will center ourselves instead of centering others. And we can stop feeling generous with no accountability. And we may fail to address really deep-rooted structural issues with our interventions. So now I'll present about rethinking global health training. Let's go back to our first slide. Can you reimagine this? 2 MPH students arrive at the University of California. They land in Cape Town for a 2-week visit. They visit the University of Cape Town campus, talk to some professors, visit some clinics, read some reports. They write up their recommendations on how to prevent HIV in Africa. They publish their paper in Lancet HIV. This happens all the time. It's happened to me, it will happen to you. So this kind of parachuting in and publishing papers about how to do things in another setting happens all the time. So what can we do as global health actors? And this is another paper that I'll give you the link to, talking about allyship. And allyship is not an identity. It's a lifelong process. So this is not something that will happen tomorrow, but hopefully we can all leave here together as really pushing towards being an ally, of building relationships based on trust, consistency, accountability with marginalized individuals and groups of people. Now I'm going to give an example. of collaboration. I'm not saying that we're perfect or that we're doing everything right. I'm going to actually give us a critique of our work. So this is an example of my collaboration with my colleagues in South Africa on preventing HIV in pregnancy and postpartum. And this is me at the WC actually wearing the same blazer. The only clothes I have. Preventing HIV in pregnancy with my colleagues from the University of Cape Town. So in this collaboration, I have an honorary faculty position at the University of Cape Town, and we've collaborated over the past 8 years on research to prevent HIV, including opportunities for mentorship and training of UCT and UCLA staff. So I'll put this into context for our PrEP PP, which is an NIMH-funded 5-year clinical trial that's PrEP in pregnancy and postpartum. And it was with myself and with my colleague Landon Meyer from the University of Cape Town. Just to give you a background for those of you who are unfamiliar with this area, is that HIV acquisition is exceptionally high during pregnancy and breastfeeding. In this recent paper, they found that there was a higher HIV acquisition risk in late pregnancy and postpartum when compared to non-pregnant women. So you can see the relative risk here in early pregnancy, later pregnancy, and the highest was actually in the postpartum period, where the relative risk was about 4 times that of non-pregnant participants. Why? Why is it so much higher in this population? There's a few risks that we want to identify that are biological and socio-behavioral. In biological, if you've ever been pregnant, you know that you have hormonal changes. You know you can have STIs, including bacterial vaginosis, pregnancy-induced immune adaptations, including activated innate immunity, suppressed NK cells, and alterations in the microbiome of the vagina. And even during breastfeeding, you can have low levels of estrogen that can increase the biological risks of HIV acquisition and STI acquisition as well. Socio-behavioral factors that we've published on, including from our team in Cape Town, is that women tend to not use condoms during pregnancy, even following pregnancy. Sexual networks, that many people have more than one partner or their partners have more than one partner. Intimate partner violence is a chronic problem. Stigma, which can also reduce HIV access and use of prevention and treatment, and substance use, including alcohol use, is a big problem in our population. This is the UNAIDS report from this year. 1 in 4 infant HIV infections are due to acquisition. So you can see in red those that are due to HIV acquisition or incident infections. In pink, it was, and blue is more along the cascade of women not receiving antiretroviral therapy on time. And globally, 1/4 of infections, but in the region where I work in East and Southern Africa, 1/3 of infant infections are due to incident HIV in pregnancy and breastfeeding. And there was 29,000 infant infections last year, 16,000 infections in our region. So PrEP, I'm sure most of you have heard of PrEP, or maybe you've even used PrEP. Oral PrEP has been shown to be safe and effective. So when I arrived in Cape Town 7 years ago, PrEP was not readily available, and it was actually contraindicated for use in pregnancy. So this is our study from pregnancy outcomes. So ours and others have published several different papers to show that oral PrEP, TDF, FTC, is safe to take in pregnancy. You can see the composite adverse pregnancy outcomes did not differ between those that were on PrEP with outcomes that were biologically measured in blood versus those who were not on PrEP. And there was a recent meta-analysis that showed the same with perinatal outcomes with women that were exposed to PrEP. And similar data has been shown in Kenya as well. New PrEP modalities are coming out, and I'm sure you've heard of Apretude or cabotegravir and other methods. And so we're also excited about using these methods in this population. Injectable cabotegravir is an intramuscular injection every 8 weeks. Lenacapavir is a subcutaneous injection every 6 months, which is still an investigational product until they get approval. And the dapivirine ring is not approved for the United States. In the United States, the FDA has not approved it, but it's approved in Africa, certain countries of Africa, and it's inserted in the vagina every 4 weeks. And I'm also including differentiated PrEP delivery because in my mind, these are all strategies that will help improve PrEP use. So we're also evaluating multi-month dispensing of PrEP, pharmacy, community, rapid queue pickup, and use of HIV self-testing for PrEP continuation. This is a paper from my colleague Lee Johnson and my team modeling the impact of CAB-LA in South Africa. They've modeled that without PrEP, there'll be 1.3 million new HIV infections. I think it's hard to put your mind around it, but we have the largest HIV epidemic in the world. And this is over the next decade, including 100,000 in pregnant and breastfeeding women, 17,000 in infants at or before birth, and 35,000 in children through breast milk. The model used 3 scenarios that our data helped inform about oral PrEP use, CAB-LA, and then the choice between the two. And it was informed by our data, as I said earlier. So you can see here in the graph that oral PrEP had the lowest reduction in HIV incidence across all 3 populations. It was about 9% reduction. When you introduce injectable PrEP, it's about 41 to 43% reduction in pregnancy and in infants. And the choice, if you have the choice between the two, you have similar reductions. So about 39 to 40% reductions in pregnancy, breastfeeding, and in infants. So given all of these models and given all of the safety that we know that PrEP is, we designed a cohort study, which was an observational cohort of 1,300 pregnant women without HIV. And our counselors provided counseling on HIV, testing, and then offered PrEP at each visit. Women could start and stop PrEP at any time. We followed women through 12 months postpartum to evaluate the proportion who initiated PrEP and their associated risk factors, the proportion who were retained in care, and the proportion who adhered to PrEP over time. And this is a mixed methods study. I just want to give a shout out to mixed methods people. I'm an epidemiologist, but I think the mixed methods, some of the qualitative data we collected is actually more interesting than the quantitative data. I won't present it, but I'm happy to share it with you. But the mixed methods approach is really important in your future research. So of the 1,200 women that we enrolled, 1,000 initiated PrEP at their first antenatal visit, so 84%, which was quite high. The median age was 26 years, so women could be 16 or older. Gestation age was 21 weeks. Most were sexually active, they were pregnant, and most reported condomless sex. 60% were unmarried or cohabiting, and over half did not intend to get pregnant. So those of you working in contraceptive and reproductive health, it's really important that we think about the contraceptive access alongside the HIV and STI prevention and treatment. 13% reported intimate partner violence, and a third were unsure of their partner's serostatus. 50% reported substance use in the last year. Most of this was alcohol, but we also have problems with methamphetamine and other drug use. And only 26% had heard of PrEP before. What about equity? So I challenged myself on this slide to really think about what about equity and the people we reach? You might think we're reaching pregnant South African women and they're all equally of need. But so all the women are from the local community. Some of them are from informal settlements or townships, post-apartheid South Africa. All of them are Black women. Some of them are foreigners, but we're not really sure of the percent because of xenophobia. So people don't tend to tell you they're from Mozambique or Zimbabwe. However, 2/3 of the women who continued on PrEP were middle to high socioeconomic status. So this is really important when you look at studies, even in Africa, to look at who's getting the access to the products, who's continuing, and what is their socioeconomic status. And reviewing now really how to reach the lower socioeconomic status who might come in late for antenatal care, may not come in at all, and may have problems with transportation and other variables. In our study, we evaluated persistence, which means continuing on PrEP over time and receiving a prescription. And here we evaluated by pregnant and postpartum status. In blue, dark blue is the pregnancy, and in gray is the postpartum. And you can see over time that women that are pregnant in antenatal care are more likely to continue on PrEP because they continue to be engaged, whereas postpartum, it's a lot lower. We're now implementing this stepped care study really to reach out to more postpartum women, including community delivery of PrEP as a result of this trial. So it's lower in postpartum, you can see the adjusted odds here. And to improve persistence over time, we're also using biofeedback. So we're using urine tenofovir tests from Monica Gandhi's lab at UCSF to give people feedback on their PrEP levels, differentiated delivery in postpartum, including community delivery when they're no longer in antenatal care. And this is a randomized trial that we're in the process of collecting data for, so we'll have results next year. So I really want to talk about the importance of PrEP continuation in postpartum. Most of our seroconversions in this cohort study were in postpartum period. We only had 1 pregnant woman who acquired HIV and 15 pregnant postpartum women who seroconverted. We had 2 infants who are also HIV positive, which was 12.5% of our seroconverters. And 1 was in labor and delivery, and the other infant was diagnosed following breastfeeding at 6 months old. Most of those who seroconverted was due to discontinuation of PrEP. So you can see here that 10 had started PrEP but discontinued over 6 months before. 4 took PrEP intermittently or stopped a month before they seroconverted, and 2 women never started PrEP. So it's really important to think about not just who starts, but who continues, and the protective benefit through the postpartum period. And that's what led us to our current study. These are the barriers we've found, mostly through qualitative research, to oral PrEP. There's logistical, daily pill-related, and sociocultural. So the first is really forgetting to take PrEP daily. If you've ever taken a pill daily, it's hard to remember. Being away from home when PrEP should be taken. Logistics around PrEP collection and prescription collection, especially when not in antenatal care. Transport and financial barriers. Side effects about the pill. If you've ever taken PrEP or ARVs, they do make you nauseous, and especially if you're pregnant and you're already feeling nauseous and you're already vomiting, it's difficult in the 1st and 2nd trimester to take a pill as well. So we counsel a lot around taking it different than your antenatal vitamins, your folic acid, and taking it at night. But still, the side effects are a significant barrier. And the pill burden, they're big pills. Sociocultural is really around anticipated and experienced stigma. So a lot of people think that PrEP is ARVs and that women are living with HIV. And unfortunately, even in South Africa, we have the largest HIV treatment program in the world. There still is a lot of experienced stigma. And limited disclosure about PrEP use. Concealment of PrEP especially is important. Sarah Schultz-Dean has also done analysis on this. We're about to publish her paper from her MPH around the importance of PrEP disclosure on PrEP continuation. So that was a clinical trial, and what we're doing now is we've changed the policy. We were effective in changing the policy, showing the data, and now PrEP is part of the standard of care, even for pregnant and breastfeeding women. So we wanted to translate our results into implementation science study to scale up PrEP and antenatal care. And what we proved, or we showed in this paper that was published just a couple of months ago, and these are the posters that we had printed in the clinics, really focusing on a seroneutral approach. Whether you're living with HIV or not, there's ways to prevent HIV in your infant. So these are the steps that we've taken in antenatal care and how we've done with integrating PrEP into antenatal care in South Africa. So in a nutshell, this is what we're advocating for in the region and globally. I'm part of a WHO working group as well about PrEP and pregnancy, including cabotegravir and other long-acting methods. And we're really working with the government, researchers, program managers for NGOs, and the World Health Organization to improve access to and counseling for effective PrEP use for all pregnant and postpartum women who need it. We didn't do any risk stratification to identify you're at risk, you need PrEP versus you're not at risk. But other colleagues have done those, and they show that the risk stratification don't help, that women oftentimes underreport their risky behaviors. And so it's really important just to provide access, and people will tell you if they want to use PrEP or not, regardless of whether they have an STI or multiple partners. Simplifying access. So we're working with the government right now and the WHO to really simplify, decentralize, removing all of the prescribing lab drug access barriers to improve continuation, including some of the labs around hepatitis B and creatinine levels. We're also including differentiated community delivery in postpartum, which includes HIV self-testing using OraQuick, so the oral HIV test. And then advocating for choice. There's a lot of advocacy for choice. Our specific aim is to ensure that pregnant women and postpartum women get choice, including lenacapavir, cabotegravir, and rings, and oral PrEP, to improve effective use. There's not going to be a magic silver bullet for any of these one products, but now we're developing in collaboration with our colleagues at the University of Cape Town, and which I'll present on now, really about how to ensure choice in this population. Health education and training in providers is really key, and to decrease stigma in this population. So now I'll talk about, I don't know if there's any questions before I go on to our collaborations.
No, I'm going to look at that. No?
Yep. Okay. Any questions, you can let me know. So CHIPS, we're all here from CHIPS. We all know what CHIPS is. The UCLA Global Health Program trains medical students, and we have the new director of Global Health Program here, Sad, is here if you have any questions about the Global Health Program. So I work with both CHIPS and GHP. The GHP is at the School of Medicine, and we seek to create reciprocal long-term collaborations rooted in equity, trust, and mutual respect. Students, trainees, faculty work alongside colleagues around the world on multidisciplinary educational programs, clinical training, patient care research. And so I focus mostly on the research side. And the CHIPS funds mentorship programs for early stage investigators. And what I've noticed in the CHIPS programs, and I just brought this up, is that 9 out of 29 of your early stage investigator grants go to global health initiatives, including 2 in South Africa with me, Mexico, China, Malawi, Peru, and Kenya. However, there's very few that have LMIC mentors and colleagues. So it's something I would really encourage. Yes.
Can we talk about the other CHIPS Global Health Program?
Yes, please.
There's another CHIPS Global Health Program where we provide travel fellowships to faculty who are trying to reinvigorate and stimulate their own work in countries. So if they don't have an active research program right now, and you're interested in working in South Africa with Dvora, for example, or any other country, and you want to travel there, you have to have a specific plan how this is going to lead to a grant writing. There is a open, is it open?
Not yet, but it will be open in January. Look
Yes.
out for an email from us.
Yes. And
So CHIPS also has, just to let everyone online know, because I think I have the microphone, there is CHIPS Global Health collaboration funding for travel that lead to future collaborations and grants for faculty. Yes, thank you for the reminder. So I'm going to focus a bit on Nafisa. Nafisa Wara is a 3rd-year medical student. She's in the middle of the left. And she also had received CHIPS funding and GloCal funding, and she's here training our UCT staff on qualitative research. This is her publication. So what she did for CHIPS is assess the acceptability of long-acting PrEP among oral PrEP using women, both in our PrEP PP study in 190 women and Prima X, which is our RCT in Kenya. And she asked theoretically, if injectable PrEP were available, would you use it? And found that about 3/4 said yes. If the vaginal ring were available, very few women said that they would switch. And so there's really significant barriers to the vaginal ring, and more education and counseling needs to happen in that population in which we don't have a contraceptive ring readily available. So it's really a foreign new product for these people. South African women were also more interested in community delivery. It may be because our prevalence of HIV is higher, or we have ARVs that are delivered in the community. But when comparing South Africa with Kenya, more South African women were interested in PrEP in the community. And this led to our ongoing stepped care evaluation in pregnancy and postpartum. So whatever the CHIPS funding really helped us secure a grant and follow on with our current RCT. We have another CHIPS mentored grant, which evaluated alcohol use in pregnancy, which was with Amanda Miller, and she collaborated with Zainab Essek from the Human Science Research Council. And we did in-depth interviews with pregnant women on oral PrEP and found that most of them reported some alcohol use in pregnancy, some reported IPV, and 4 reported both. The reasons for drinking included stress, peer pressure, misconceptions about safety of alcohol. And this is qualitative again, so we got to learn about why women thought that it was safe to drink during pregnancy. Many continued to drink during pregnancy, and some altered who they drank with because of fear of judgment. And this led us to just receive this award that we just received last month from the NIAAA about mentor moms, really using mothers who have stopped drinking and are either at risk of HIV or have HIV, living with HIV and on ART or PrEP to deliver these interventions. So we're very excited, and thank you again to CHIPTS for these grants that have enabled us to get these awards. So now that I've presented some of the experiences we've had with the global health research and bringing in trainees and students, what we want to really focus on is how to prevent the parachute scientists that I mentioned earlier of people going in for 2 weeks and publishing papers about what to do. So we've had over 8 years experience, and I've had over 20 students and fellows, including some from the Bixby Center. So very excited to have these students come in with great ideas and good intentions. But some of them have really strong opinions or hypotheses that they arrive with saying, we're going to prove this or we're going to show this, that they want to evaluate. Usually we give them access. I'm very collaborative. If you ever worked with me, you know, I like to promote student research. So we give them a lot of access to our resources at the University of Cape Town, people, time, data. And some of us even go forward to publish and do grants together, as I mentioned with the previous 2 examples of Nafisa and Amanda. Most students, faculty, researchers are excellent allies. So we're talking about the allyship and work together with our UCT partners on analyses, clinical work, and other initiatives. Some are not prepared, though, at times to be an ally and to really give the time and the effort it takes to collaborate. And some of us are, especially with epidemiology, I think, is that we like to just sit at our computers and do analysis by ourselves. So some of them do require more mentorship and support. So what can we do together as a UCLA community really to improve our collaboration and ensure reciprocity for our UCT learning and research? So the first thing I'm going to present is about authorship. We all know about authorship. So the equity in authorship is key. And you could read some of these equity papers, but really about colonial science. There has been some effort by PLOS, Lancet, Cell Press to prevent parachute science. And they have foreign researchers are required to complete an inclusivity in global health questionnaire to improve transparency. Lancet will reject. I know people that have been rejected from Lancet because they didn't have an African author. And the Royal Society of Chemistry started a collective action and joint commitment for pushing for this. The next one is really striving towards true equity in global health training. So we have to think about how we do training. So collaborators should prioritize locally derived and relevant solutions to global health issues. So we should always come in and try to understand from our partners and global health researchers, come in and really collaborate around coming up with hypotheses, interventions, and solutions. We should be paired with high income and low income as many levels as possible. So not just at the PI level, but also our field teams, our lab staff, our trainees, our statisticians. Budgets should also be provided for paired funding, and sad news, I'm really advocating this from the Global Health Program, is that we need to give funding to the University of Cape Town so they can come here and learn from us, not just send us to them. So we're working on proposals now, if you know of anyone that's interested in this area of funding, including bi-directional travel, conference attendance, and dedicated research time for our UCT and for our LMIC colleagues. Collaboration should mutually assign clear roles and responsibilities which value, leverage, and share the strengths of all team members. And these contributions must be appropriately during the dissemination phase. So not just during the research, but also when we disseminate the research, we should allocate equal roles on authorship of publications and conference presentations. So if you're interested in these steps, you can take this QR code, or I can share the article with you after. But this really has key steps to the design, implementation, analysis, and dissemination phase of how to improve global health equity throughout each stage of the research process. So what have we learned? What have we learned over the past 7 years that I've been in Cape Town? We're ongoing collaborating to ensure funding, including conference attendance for our UCT team to attend and present conferences. Kalisha Bhimraj, who's our UCT data manager, I think she's on the Zoom call. She just recently got a fully funded scholarship and got a new investigator award at HIV R4P, the conference in Lima last month. And it was an excellent presentation of our PrEP PP data. We're also supporting early stage South African PIs to get their own K43 awards. We're assigning clear roles and responsibilities for all phases of the project, making data analysis and manuscript writing tools and training available for all team members who may not have had the training before on how to write a manuscript. We utilize local capacity in all roles, including data management, analysis, and dissemination. So these are things I think we're doing fairly well. In progress, we're pairing UCLA and UCT trainees together. I didn't realize the importance of this, I think, in the beginning, but you can see Nafisa here with our clinical nurse and some of our trainees who's with us in Cape Town for 18 months so that they can publish together and work together. Longer training opportunities are better, and shorter are more likely to parachute in and expect to publish results. We're also really working on co-writing, having first authorship roles. This includes Nafisa and Sumaya Dadan, who's from our study in CROI and HIV R4P. We need to redefine significant contributions to manuscripts to especially allow for first and senior authorship. And we need training opportunities from our partners in LMICs. So more funding should be available to them to travel and to come here and collaborate. LMIC partners must identify and lead research opportunities and solutions instead of having all of the interventions and solutions coming from our side. And then connecting the LMIC trainees with UCLA and wherever you are in the world to obtain this training. And they will need additional funding and time to do these trainings. So what can we do better to work together as allies? I'll leave you with this quote in my email if you want any other information about our work. Is high-income country institutions like UCLA need to learn the lifelong practice of allyship, that is building relationships built on trust, consistency, accountability with marginalized individuals and groups in LMICs. Thank you very much for the invitation to talk today, and I'm happy to take questions.
Yeah, so we'll see if there's some questions in the room.
Joseph.
And we can open the chat as well. Do we have a question in the room? Oh, over here, and then, go ahead.
Well, thank you very much. It was a really tour de force presentation. So I happen to have the first name of your middle name, Joseph, which I think is
It's actually my maiden name, so
Oh,
I
it's your maiden name.
I double barreled it. Yeah.
Okay, wonderful. Okay, so my name is Joseph Ventura. I'm a member of the faculty here in the Department of Psychiatry. And as I mentioned to you, I have a NIMH funded grant in a low and middle income country. So I feel proud of the fact that you mentioned all of this stuff because I'm working very diligently with Tunisia and my Tunisian colleagues to do exactly a lot of what you suggested. So all I want to do is just share one issue that I'm running up against, which is I have a psychiatrist that I'm working with on my team. As you know, I mentioned I'm working on a clinical high risk project there, and we're doing interventions in clinical high risk in Tunisia. And so one of the things I'm trying to do is to get one of my colleagues to go to a conference in the United States in April. It happens to be the Schizophrenia International Research Society meeting. That's an annual meeting, and it's in the United States. So she's having a hard time getting a visa, but that's the Tunisian government. The Tunisian government is providing some obstacles there. There's another colleague that I'm trying to get out of Tunisia and into one of the European congresses, like the European Psychiatric Association meeting or the Early Psychiatric Intervention Congress in Berlin. And she's having, it's difficult to even get an appointment to get to the Tunisian government to get a visa. So I just thought I would share that with you. That's at the government level. They're giving their own citizens a hard time to get a visa to get out of the country. So I just shared that with you for your comment.
No, thank you, Joseph. I think that the barriers to getting visas for conferences there's a lot of different levels of barriers into getting a Schengen to go to Europe or a US visa. And so it starts at the country level, of course.
Yeah.
But also the US consular office rejects visas all the time. We had colleagues who were rejected visas to attend. They also have to show that they have a lot of money in their bank and they're coming back and for students, that's exceptionally hard to show I have hundreds of thousands of dollars or even $10,000 in the bank that was going to keep me here and a job because they're students. And so a lot of our students get rejected because but that's on the US side. So there's multiple barriers, and there's really a pushback to have conferences in LMICs. So the AIDS conference next year, for example, is in Rwanda.
Yeah.
And we're hoping that all of our African researchers can go to Rwanda more easily than going to Canada last year. Yeah.
Right. Great
Yeah.
comment. Great suggestion. Thanks.
Yeah.
That's really helpful. Thank you very much. Sorry.
Anyone else?
Good afternoon. It was a great talk. One of the things I've done in my research as a community member, when I encourage the PIs I work under for the main paper, put the whole staff on there. When you talk about equity and all of those things, even though I don't have a PhD, I can contribute. So if you want to start someplace, put the entire staff, the community advisory board, at the end of the acknowledgements, all of those things. But I'll talk to you more afterward because it's a few things, because I know there's some online and stuff like that. I want everyone else to share. And I know everybody.
It's a great feedback. And it took me a while as a researcher to realize, how to make it more equitable, is that I thought people that analyzed the data or wrote had to be, authorship, but we've increased the authorship to our research assistants who collect the data, to our community members. And the feedback that they come back with is better than some of our statisticians. No offense to the statisticians, but involving the community and the research assistants who are collecting the data, it's really important. So I think we've done better in the past couple of years, but it took us a while to get there. Thanks for that feedback.
I'm going to jump in, just have one question. Could you, and I've struggled with this talking to Annie Vermoyen, who's in this, that the model for the younger investigators is different than the model we had when we did global health research. We went overseas, we spent years doing that, and the opportunities now with more equitable models mean also less opportunities for US young investigators to get involved in global health. And the issue with shared publication and more means that it's harder as a young investigator, if you want to do global health, to get your publications, to get your grants. So what is the future model for junior investigators and people in this new world? And what would you tell the medical students that want to do global health and the graduate students that want to do global health? Like, how are they going to do that with the pressure on them to publish, to get first author publications and do that? How are we going to do that?
No, it's a good point. And I think that the field of global health has changed a lot. There's even an African agreement right now of data sharing. I think it's a continental wide, but I know we've signed on to it in South Africa, is that we don't want to export our data anymore. We want to really keep the data in country in South Africa. My colleagues from the University of Cape Town are really keen about keeping the data here and coming up with data sharing agreements that can take a while to sign. So if you really want to use the data and take it to UCLA, it's pretty much impossible if you don't have someone that's like me, like your interlocutor, that can help with that. I think that there's no longer a science where you can go in for 3 weeks and get things done. I think you have to invest more time than we did in the past. Time means, for me, the way I got to South Africa is I had a postdoc, but then I got a K01 from Fogarty. And the Fogarty K01 makes you work 50% of your time over 5 years in a low and middle income country. I think you have Fogarty as well in China. And so it forced me to be in South Africa and be based there and then do my research while I was working there. So I think you have to invest more time and more resources to make it work. And collaboration is key. So knowing people that can help you navigate, but you're going to have to do data sharing agreements and that sort of thing. And those things take time. I want to quote from SAD, though. We had a meeting earlier this week about publishing, is that publishing is not the be all end all. I think a lot of students come over for a week or two and they say, okay, I'm going to publish a paper. And I think we have to think differently than just publishing together and getting a first authorship. Is there's a lot of ways of being an excellent ally and global health ally without having to publish a paper as a first author. And so there's other ways of really mentoring students and coming over without necessarily having the outcome be a publication. I know that's difficult for PhD people, but yeah.
That's a great question. And I struggle with it too, because what you're also describing is that the incentive structures in our setting, UCLA and across this country, are set up so that we're structurally sort of forced into, elevating ourselves and prioritizing ourselves over our, and that runs right into the, face of equity. And so for me, sitting at it, having thought about this and worked in this space for 30 years, it requires leadership to change the incentives. Like we have a job to do as leaders to change our internal incentive structures. And that means advocating, at the leadership level, what does it mean for a junior investigator who's sharing a K or whatever, like, we have to think about, promotions within academia in the US for investigators who are doing global health work differently. And we have to value their contributions differently, right? It can't be the same paradigm if we're taking equity seriously.
Agree 100%. And that takes time. Like we said, it's a marathon, not a sprint. This is a continued advocacy that we need to continue doing at the leadership levels that you guys have.
So one thing that I'm curious about is what more can be done at the level of the funding mechanisms? Because like, I know, for example, I worked on some PEPFAR funded projects in Kenya. And so that money was going to the US university and then going, into the programs. And then over time, it did feel like there was some of shifting of the funding going more directly to the countries, but there was still sort of these like, there was some kind of stuff where things were set up where it was like a organization that was like still very much closely tied to the US organization, even though it was in that country. And so are there things happening, or are there pushes to make it more the money goes directly to the, like the US funded like PEPFAR money and those sorts of things go more directly to the countries? Or is that something that still needs to be pushed for?
Yeah, it's a great question. For the NIH, most of my funding is from the NIH, less so. And I've been on review panels before with the NIH, and I bring this up a lot, is that we see a lot of grants getting funded that have no LMIC collaboration, no MPI, like multiple principal investigators, no co-investigators. And for me, I would reject it. So I gave a really low score, and the people said, "Why did you give it such a low score?" And I said, "There's no one from Malawi on this grant. Like, how can you fund something from Pittsburgh without a Malawian that's leading it?" And they were kind of shocked, like, but it's so and so from Pittsburgh. Don't worry, they weren't from Pittsburgh, but they're really shocked. So the NIH has a ways to go, I think. Even the Fogarty funding that I received, it still primarily goes to US institutions, and their preferences to give to the US institution that then gives a subaward to the others. PEPFAR is funding more and more local organizations. I think it's happening. But like you said, there's a lot of like FHI, Family Health International, which gets billions. Do you like FHI? Okay. So FHI has programs in all the different countries where they call FHI Zimbabwe or FHI South Africa, but the funding still goes through FHI North Carolina or in DC. And so it's happening on paper, but like the true collaborative funding direct on the ground has a ways to go. The Gates Foundation is pushing back. The Gates Foundation is funding more and more on the ground. So they are strategically, despite the pie chart, I think it's changing now because they are funding more and more local organizations. So there are some changes, but it's going to take time. And at least in my understanding from NIH, it's not happening at all, unfortunately.
Can I make a point?
Yeah, of course.
I'm on the review panel for the training grants.
Yeah.
It has changed a lot in terms of the Fogarty model. So Fogarty training now have to be pretty much based in the local country, and the training has to happen there. And the model that we used to have, we brought all these trainees here and it was funded here, has gone away. And
so Fogarty is a good example.
For the training.
For the training, yeah.
But the bar is super high.
Yeah.
They expect the local PIs to have had their own NIH grants. They expect a number of, and very few countries can meet that bar except UCT.
Except UCT.
But it is changing that.
If I can, I've been waiting patiently. Tom Bellin from Biostatistics and the CHIPTS Methods Core. Thank you. It was I've enjoyed working with you, but it's great to fill in some of the gaps. I was really learning a lot from your presentation. I had a comment and a question. The comment is that some of the ideas about how to improve global health research reminds me also of ideas for better community partnered research in this country. And so some of the ideas of partnering effectively with local organizations, sharing co-authorship, and some of the work that I've done in that realm was really learning experience for me about, and I would get questions about, is it okay if we restrict the attention of the focus of the data collection to a certain area that has another initiative going on? I said, well, that's really a subject matter question that I don't really know the substance of, and you working down in the trenches do. And so that kind of on the ground insight is really valuable and important. The question I had, you answered it, anticipated it somewhat with your comments about getting a Fogarty grant. I was going to ask a little more about your personal odyssey of how you got to where you are, and maybe even if you can take a step further back of when you were finishing your doctoral program and thinking about what to do, and trying to find out what the next career steps were. How was it that you came across this Fogarty program that ended up landing you where you are and that kind of decision making that you were facing?
Yeah, thank you, Tom. And it's great to see you as well. I think for your first point about the community organizations and the collaborations is very similar, right? So you don't have to think about this as a global health problem. It's also a problem for us who work in the community and getting greater engagements with community members, like we talked about earlier. I'm kind of an anomaly, I guess. I did Peace Corps right after college, and I lived in Africa and worked in Africa before. And so when I graduated, Pamina knows this, she said, why don't you just stay here and work in LA? And I said, that's so boring. But I also have a family that's South African. My husband's South African. And so it was kind of a natural transition for us to move back. And when we thought about moving back, I picked UCT because I thought it is the best university in Africa, probably in terms of an academic institution. And I'm able to do a lot of really good research there with my collaborators there. And so I've learned a lot from them equally as they learn from me. And so that's why I sought to go back. I've always done really global HIV work with women. And I did think about it for like 3 seconds to stay here, but I'm glad that I moved back back to South Africa and I'm based there. I also think that being based there as a faculty, I'm able to mentor students and I'm able to do better research rather than if I were based here, I would have to go there, a couple times a year and wouldn't have the same contacts that I have with the government, the policymakers, the researchers on the ground that I was able to forge. And so I'm very fortunate to have a position to enable me to be based there.
Okay, I think we have to wrap up. And thank you, everyone. That's great. I don't know if there were more questions in the chat, but I'm sure Dvora will probably get to those. And those of you who are in my class, she's going to come give another talk at 2. So you can catch up with her right now if you want. That was always awesome. And thank you for pushing our limits on thinking about, we need a new model for global health.
Yeah.